the conversation that we first have regarding to the Pinhole Surgical Technique, and I'm aware that you are one of the mentor assistant for Dr. John Chao. I am in your group, close group with all the professional specialists and general dentists who do Pinhole Surgical Technique, and I am so happy and honored to invite you to this interview to get to know more about the technique and how you can introduce the technique to the whole entire world. That for dentists who want to serve the patient with the minimum invasion technique. Would you tell us more about yourself and
Sure. Well, thank you very much for having me. My name is Dr. Deanna Schnitzer. I practice in Lakewood, Colorado, and I have been Pinhole certified. I went to Pinhole Academy over 3 years ago, and for the last year I have been helping Dr. Chao as one of his Pinhole instructors at Pinhole Academy. This is a procedure that I do every day in my practice, so it's something I feel very comfortable and confident doing and talking about, so I'm looking forward to sharing all of that with you today.
Absolutely. I on the closed group study group, I see you have pretty much all the answer to every single question that every student, whether they've been with the academy for a while or they haven't, or they first got in, pretty much you have all the answer before Dr. Chao able to even answer. So I am so thrilled to have you on the
well, he's probably busier than I am. That's why. No, I'm not sure if I have all the answers, but I've done hundreds and hundreds of cases, and I guess when you do hundreds and hundreds of cases of anything, you learn the ins and outs and you learn the pitfalls. So maybe if I can help somebody out so they don't have a problem that I had, I feel like I've done a good job that day. So.
Yes, I agree that whenever somebody posts a case on the group, and pretty much by looking at the picture, you can pretty much tell him or her why didn't it turn out right. I see you pretty much understand this technique so clear and so so pretty much like in depth. So that's the reason why I didn't invite you for this conversation, because it not only helped the dentists that who haven't been taking the class, or the dentists already taken the class and having a concern. And so I am thrilled to discuss about this technique with you. So you are from Colorado, right?
Yeah, I practice. I'm originally from near St. Louis, Missouri, but I practice in Lakewood, Colorado. I'm looking out my kitchen window today, and I see a bunch of mountains out there. So it's a lovely place to live and a lovely place to practice.
That's beautiful. That's great to know. Would you tell somebody that who never heard about PST, Pinhole Surgical Technique, and what is it about, and why we do it, and why is it getting more rapidly become one of the technique that almost like the first choice for the patient, with gum recession problem?
So I guess the Pinhole Surgical Technique is just another technique to treat our patients who have gingival recession. It's a nice, minimally invasive way to treat. We don't use scalpels, we don't use sutures, which are things that patients definitely have a lot of apprehension about. And we get really, really nice results with significantly decreased levels of discomfort for the patient. So not only is it maybe not as scary as some of the other techniques in the eyes of the patient, but they seem to be, in my experience anyway, a lot more comfortable post-operatively.
I see. So in your experience, what is the worst kind of post-op complication that you ever seen with this technique?
I haven't seen too many bad ones. One of the great things about this procedure is you don't routinely have to prescribe antibiotics.
Wow.
Which is great because antibiotic resistance is issue right now, and will be probably for the rest of all of our careers. Another great thing is you don't need to prescribe narcotics, which I think, just as a society, the fewer narcotics we can get people started on, the better off we are. Post-operative complications are the same as basically any other type of oral surgery. You could have bruising, swelling, bleeding, infection, but I will say that the post-operative complications that I've seen with this particular procedure are pretty few and far between. The few cases of infection that I've seen were easily controlled with a round of antibiotics. And I do see, like I said, I do see swelling post-operatively, but very little discomfort. I have not a single time that I've performed this procedure prescribed a narcotic. Tylenol and Advil or ibuprofen and acetaminophen is really all that the patients need, and usually just for a day or two.
Really? Just a day or two? You don't prescribe more than like 5 days or anything like that?
No, and I don't prescribe at all. They just take one over-the-counter Tylenol and one over-the-counter ibuprofen, and that's all they need. I did a case yesterday morning. I saw her this morning for her post-operative visit, and I said, "How you feel?" And she said, "Oh, I'm a little swollen, but it doesn't hurt. I didn't take any Tylenol today because it didn't hurt." And I pretty much hear that from every single patient. A little bit swollen, but no pain, which is really, really nice, because a lot of the other procedures that we do with gingiva are not necessarily comfortable for a lot of people. So it's really nice to give patients a very low discomfort option.
How long would it take for you to get an upper arch full mouth recession, upper arch recession case done for?
Well, I guess that depends on the case. I have some cases, I'll show you one case I did in 12 minutes earlier, but some cases take, maybe 45 minutes to an hour, with anesthetic and stuff like that. So once you get a few cases under your belt, it can be a pretty time-efficient procedure.
That's still really good timing. If you imagine if somebody doing upper arch treating the recession for every tooth, but using a conventional approach, I don't know, it could take hours, right?
Yeah, if you're treating 10, 12 teeth at once, if you're treating it conventionally, that I don't even know, you couldn't really do that. You can only harvest so much tissue.
Yep.
So the patient's probably looking at multiple procedures, multiple office visits. One of the benefits of this procedure is you can treat the full mouth at once. You could treat 32 teeth in a couple of hours, and the patient only has to go through the surgery one time. They don't have to cover a few teeth and then wait for it to heal, and cover a few teeth and wait for it to heal like you do with some of the other treatment options. So that's another real advantage to this is you can treat a lot of teeth all at once, and so the patient only has to be surgerized one time.
So let's say if you do the lower arch, would you numb like IA or you numb the infiltration around?
Personally, if I'm doing like a full lower arch of surgery, I would block on both sides to anesthetize the teeth. And then I do some, a long buccal and some buccal infiltration to make sure that the patient isn't going to feel anything on those buccal gingival areas. So I always try to make sure I have adequate anesthesia. I don't like my patients trying to climb out of the chair halfway through. So I try to make sure they're really nice and numb and ready to go. And usually the number they are, the faster it goes, because when somebody wakes up halfway through, that's never fun for them, and it's never fun for the dentist. So I like to make sure that they're ready to go in the beginning so that we can just go and finish.
I see. How did you get to know this in non-invasive approach procedure? How did you start it?
Well, I got some literature in the mail from Dr. Chao in his office, and then I went and read his studies that he published. And then, I did my own research and actually knew somebody who had taken the class, and they had a good experience. And the last thing I did was I actually called my dad, who is a periodontist. My dad's been a periodontist since longer than I was born. And I called my dad, and I was like, Dad, I've been thinking about taking this class, and it looks pretty good, and it's, it's not the cheapest class I've ever took, but it looks really legit. What do you think about it? And he said, well, I signed up for that last week. So me and my dad actually ended up taking the class together. I'm a general practitioner. He's a periodontist in St. Louis. But we ended up taking the class together. It was really fun. And then actually in September, he audited the class. He retook the class so that I could be his instructor, because he said he didn't like that I was better at it than he was. But he wanted to relearn it.
No wonder why you have the surgeon blood in your
it's
in your hand. That's why I got like, wow, how how you do so many cases, and it seems like it's not. This is like easy for you, When I first took the class, before I even took the class, I do regular surgery, all kind of stuff, and then with this technique, it requires very unique training. If you don't have training, you can't do it.
No, you definitely need to attend Pinhole Academy in order to properly do this procedure. The instruments are pretty specialized, as you know. The technique is, it's pretty technique sensitive. Mm-hmm. So this probably isn't something you could even properly learn. This isn't something you can learn on YouTube. No way. It's just, that's not the way it goes with this one. Yeah. But I will say that the investment that I've made in learning the Pinhole Surgical Technique, I've gotten a really great return on my investment. And it's a class that I get so much positive feedback from dentists from all over the world. So it's definitely one that I would personally highly recommend, and not just because I'm there. It's just it really is a really good course, and it's a wonderful service to be able to offer your patients.
I agree with what you say, because it's not the same with the conventional approach where you cut the gum from other place and you create two sides of surgery for one purpose, and so I think definitely it's a very interesting procedure, and
there's a lot of some people are really, really good with allograft. People can do things with allograft. Mm-hmm. Allograft, in my opinion, it's not an easy material to get really, really good at. Mm-hmm. I always preferred to work with the patient's natural tissue, and with Pinhole, we just work with the patient's natural tissue. So it's really nice.
Yeah, I agree. So one of the things I want to ask you is there any permanent damage in case like a new doctor want to take the class and somehow he torture the tissue somehow,
Not that I've seen. I mean, I haven't seen everybody's cases, but from what I've seen from other people, most of the results that I see are beautiful. And one of the really great things about this procedure is it's quite forgiving. Even when, something doesn't go exactly the way you think it might, it tends to heal up really nice anyway. So I'm not aware, Dr. Chao might be more aware than I am. I'm not aware of any, problems with permanent disfigurement or anything like that. Not at all. Like I said, I've seen a lot of beautiful, beautiful, beautiful cases, and even the cases where somebody goes, "Hey, this one didn't turn out exactly how I expect." In the end, it still turns out all right. So you're usually not ended up any worse than you started.
I have a few good friends. They do all kind of surgery themselves. The conventional surgery like connective tissue graft, free gingival graft. They done all of that, and tunnel approach surgery, and they concerned. I told them take the class and find out. And they say, I heard a lot about the long-term effect. I mean, the result, this and that. Would you tell them? I mean, what would you tell them about the long-term result in terms?
Well, I took the class over 3 years ago. So my results, I see 3-year post-operative results, and I'm very happy with what I've seen. I've seen cases in person of Dr. Chao's patients that are 10 to 15 years old, and they look just as good as his 24-hour photographs. So I know that Dr. Chao is in the process right now of publishing a follow-up study to his original study using most of his original patients and giving, I think 10 to 12-year results. Wow. I believe his original study, oh gosh, for the life of me, I can't remember if it's a 24 or 36-month study. I feel like it's 36. I can't remember off the top of my head, sorry. But a 36-month study is a pretty darn long-term study. Yeah. And like I said, a 10 to 12-year follow-up is even longer. And I know he's in the process of publishing that right now. But as I said, at Academy, I've seen his 10-year patients come in, and people can look at them and examine them, and they look great. So I feel like this is a procedure that really does have a good record of longevity.
Mm-hmm. I also see that he's doing a lot of cone beam 3D image to study the amount of bone regrow as well as the the connective tissue. well, how far is it going along with that?
I'm
finding?
not really sure. I know that at Academy he shows some evidence that there's definitely some bone changes after the pinhole procedure around teeth and implants. I'm not sure where he's at in getting that information published, but I know that's definitely something that that he's working toward. It's very, very interesting, the things that he's been able to observe, and it wasn't even his observation. I know that the particular slide I'm thinking about in lecture, the radiologist that was interpreting his cone beam said, "Hey, look, you grew some bone," and he was like, "Oh, that's cool," and then he'd been noticing it more. So it's really, really interesting, the kind of almost the things that we didn't even know were happening that are happening underneath the surface.
How often do you come and help Dr. Chao for the additional training?
Well, last year I've been there approximately about once a month.
I see. Wow.
I think I'd be there more, but I think my husband would kill me. So
I see.
I think he wants some time too. But yeah, so I'm helping Dr. Chao to instruct about once a month.
That's great. How do you see the train? How many general dentists versus how many specialists, gum specialists, oral surgeon? Have you seen like different specialty took the class?
Yeah, I think there's definitely over 2,000 practitioners worldwide now. I believe there's about 22 or 2,300 total. The majority of them are general practitioners, but the majority of dentists are general practitioners. I think there are maybe a quarter periodontists just off the top of my head. And then there definitely are oral surgeons. I think there's even a couple of endodontists in there. Yeah. So there's definitely a good mix of general practitioners and specialists who've been trained in this procedure.
How do you feel about that? Those specialists who took the class, because you have a chance to interact with them quite a bit with this group and also with them at the individual when you teach them. How do they feel?
I feel like in general, I feel like the people who are taking the class are coming out with a really positive experience. I get amazing feedback. I have people who email me after and say, "Man, this was the best class I ever took." I have people who email me 6 months after and say, this class changed my life. It changed my practice. So I haven't really had anybody come back and say, "Well, I wish I hadn't taken it." But I know that Dr. Chao does offer, if you're not satisfied, they'll refund your money on your class. But I don't think they've ever had to do that because it's a really rewarding experience.
Wow, Dr. Schnitzer, thank you so much for your inside information about this techniques. Would you mind to share with the audience some of the case that you have done?
Sure, I'd be happy to do that. I'm going to go ahead and try to share my screen here with you, okay?
That's great, thank you.
You got it?
Yeah.
All right,
yes.
Go ahead and start here. So this is just my information. If anybody ever wants to email me or write a note or anything and ask any questions, I'm always happy to answer them. So this is a 3-year, one of my first cases that I did. This is a 3 years post-operative case. Obviously, they had a lot of recession on that first molar in the upper left area, and after 3 years, I think we're hanging tight. And considering it was one of my first cases, not so bad. Definitely get out of the furcation danger that we were in before. I consider a furcation involvement to be kind of a little death sentence for a tooth. It doubles the risk of tooth loss. So when I see this turn into this, and I see this possible furcation we were going to have turn into not a worry, that makes me really happy.
Absolutely. Look, that's incredible. Yeah, that's beautiful.
Thank you. Another case, some pretty significant gingival recession in the cosmetic zone. Some pretty steep recession on that canine too, on the upper right side. And then this is over 2 years post-operatively. And this is the case where I always go back, and I got so much tissue here that sometimes I feel like I should go back with my laser and thin it out a little bit. But it doesn't bother the patient. You can't really see it when she smiles. And it would break my heart to get rid of it, so we've just left it. Wow. But not a bad problem to have, is too much tissue when you're done. So, but I think we got a really, really nice cosmetic result. The patient's thrilled, and like I said, this is still a couple of years after her treatment. And we're
can I interject a few information? When you look at this case like this regarding the canine tooth, normally if the periodontist place the using the conventional surgery, do you see that there is the different texture of the gum outcome? Like, sometimes they have like a scar or something like that, right? This one doesn't have scar,
No, there's no scarring. It's a beautiful aesthetic result. Sometimes when you're doing pre-gingival graft, I always say it, sometimes it ends up looking like a Band-Aid. And in the cosmetic area, obviously patients aren't thrilled with that. But with the pinhole technique, since you're using the patient's own tissue, there's no scarring. There's no vertical incisions where you're going to have a big line. There's no little Band-Aid appearance to the tissue after. It all blends in perfectly. Like I said, this is a lot of tissue. This is an exception, not the rule. And like I said, if it was a cosmetic concern for the patient, I'd probably just go in there with my laser and thin it out a little bit. But the patient's happy, and I'm happy to leave it. So
it's great. It looked great to me. Yeah.
A couple other cases. This is a case, a lot of people say, well, does this work in the mandible? And this works great in the mandible. So this is a patient, Brad. He was told that he was going to need a bunch of, class 5 resins in this area, and he was not interested in that from his general dentist. So we did the pinhole surgical technique on Brad in that lower right quadrant. He did have some bruxism issues. He had a night guard that he wore from his other dentist. So I said, great, keep wearing it. That was Brad post-operatively. This is Brad after 6 weeks, and this is Brad after 6 months of healing. You can see we've got some really, really nice, thick attached tissue in this area, and not a single resin was placed. I did not have to place any class 5 resins into this patient, which he was really happy about. So hopefully maybe one day, instead of putting resin where the gum should be, we just put gum where the gum should be. That'd be nice, because resins you got to replace a lot over time, and they leak, and gum usually don't. So
right, yes, I do see that. Yeah, I mean, a lot of patients, they come into the office and you give them the choice. You can put a fill in there, or you can do a gum graft. And this is something that the picture it say 1,000 words.
Yes.
Why would you want to put something there and it will leak out the road, or it will pop out later on? And with your old gum tissue, it just rebuild back, and you don't have to worry about, redo something,
Well, what Brad's exact words was, my dentist wants to put in 4 fillings, and he said, every time I get a filling, about 5 years later, I got to get a new filling, and then a couple of years after that, I got a new filling, and a couple of years after that, I got a crown. And he said, I'm not interested in that. He said, can you just put the gum up where it's supposed to be? And I'm like, yeah, let's do that. So that's what we did.
Can I ask you a question regarding to like the etiology of these recession gum? What are those reasons? What are the facts?
Well, he obviously does have some issues with bruxism. So I'm a believer that, fremitus can cause problems with gingiva. He only had this problem really on his lower right quadrant. And I called Brad the crusher brusher. He would just take his toothbrush and he would just saw away, the teeth and the gingiva there. So we went over a lot of oral hygiene instruction with Brad so that he's not injuring himself with his toothbrush. And I think dentists, we tell patients brush, brush, brush. And some people, they take that to the extreme where they're using a hard toothbrush. I don't even know why they sell those things. Every time I go to Target and I see hard toothbrushes or medium toothbrushes, I take them and I hide them in the shoe aisle so nobody buys them. I take them away. And I guess the reason they sell them is because people will buy it, because they'll sell it if you'll buy it. But I take them and try to hide them somewhere and put them in a boot or something in Target so nobody buys those hard toothbrushes anymore.
Right. Even though you are all into the business of restore their gum, but one of the way is to take away that, so that it's almost like telling the population that they need to be aware of overbrushing can cause gum recession.
That's true. And it can, and it really can. There's a lot of people that they get in there and they take that electric toothbrush and they're just, they're just leaning on it. So a lot of what we do pre-operatively and post-operatively is oral hygiene instruction with our patients. How are they going to take care of their teeth and gums without injuring themselves?
Is there any problem with patients who use a rotary toothbrush?
Well, just after the surgery, we recommend using a manual toothbrush. We don't recommend using a rotary or an electric toothbrush. until the gingiva has fully matured, which usually is about 6 months. After that, we do let them go back to their regular toothbrush, but we give them some pretty strong instructions on how to properly use it. You know, you're not supposed to take that electric toothbrush and saw your gums off. You want to, you know, use that gently and in the proper way. So we definitely give them their electric toothbrushes back so they can take good care of their teeth and gums, but we make sure that they're educated in how to properly use that tool.
When do they supposed to floss their teeth?
Not for 6 weeks after. We do some surface polishing and things in that as part of our follow-up care. We have multiple appointments for follow-up care with the patient. And after 6 months, they can go back to their normal hygiene routine. And then after 6 weeks, they can go back to their normal hygiene routine. And then after 6 months, I allow them to go back to their electric toothbrush.
I see.
Just another case. That's rad, just a good before and after. Another case, this was a case, like I said, this was a quickie case. It was a 12-minute surgery.
Wow.
So that was 12 minutes after we started, you know, not including the anesthesia. That takes a couple of minutes too. But like I said, once you do a few cases and get comfortable with this technique, it can be very, very efficient in your office. So that's the case 12 minutes after treatment. That's the case after 1 week. That's the case after 3 weeks and after 6 weeks. So like I said, I'm not worried about her having a furcation involvement, and not bad for 12 minutes of work.
Do you see case that after the surgery, it will be more sensitive than before, or usually the other way around?
Normally, I mean, for a couple of days, they're a little tender, you know, just like any other surgery. But to be perfectly honest, since we're covering up the sensitive thing, which is the root and all that root exposure and exposed cementum. So normally I see a lot of decrease in sensitivity. Not only are we covering up the root, but we're thickening and toughening that tissue over the root, so giving it a lot more insulation to temperature and things like that. So I normally see a decrease in sensitivity post-operatively.
That's one of the reasons. Really nice, yeah, those are usually chief complaint, right? You know,
it is, yeah. Chief complaint is every time I drink iced tea, it sends me through the roof. And when you're looking at this, you can imagine why. That's a lot of exposed root structure there. So you can see how nice and thick, even just after 6 weeks, how nice that tissue looks. So definitely decreases in sensitivity is what I observe regularly.
Yep.
This is a nice little cosmetic case. I love this case because every time the patient sees me, she breaks into tears and then I cry too. But this was my patient, and she just was never happy with the appearance of her smile because of the gum recession she had here. And it wasn't necessarily, through the attachment. It wasn't to the mucogingival junction, but it definitely didn't look nice for her. And she didn't want to smile big, and she'd, laugh like this. And then, that was 24 hours after surgery. And this is 6 months after surgery. And now whenever I see her, she has a giant smile, and she starts crying and I start crying. So, this can be a very emotional thing for patients in a very good way. Our smile and being able to comfortably talk and laugh with our friends and our family and feeling comfortable and confident with our appearance is really important to a lot of people. And for this lady, this made a really big difference in her life. And that's why I like to show this case, because even though to a dentist, you're like, well, it isn't that bad, but to her, it was a really big deal. It was really life-changing for her. And like I said, she'll cry, and then I'll cry, and my assistant will start crying, and my front office starts crying, and it's great. It's wonderful. I get a lot of hugs from patients after surgery, and I didn't get that a lot when I was harvesting grafts from the palate. Everybody kind of wanted to punch you in the face after that. And now everybody, the next day they're like, I love my smile. They're happy. They're crying with good tears, not bad tears. And it's really, really rewarding.
I look at the before and after 6 month post-op, pick a photo. Look at the gum. It's just amazing. How it gets so thick.
Yeah, it's nice. It's thick. It's tough. It's resilient. It's beautiful. And like I said, it's insulating for those roots. And like I said, I enjoy doing this procedure. I am very happy with the results that I see.
Absolutely.
This is another case, not a huge case, just a little bit of recession, but this was a sensitivity case. This patient said, every time I eat ice cream, I feel like I want to die. Every time I drink iced tea, it sends me through the roof. And every time I get my teeth cleaned, I just want to run out of the room when she touches, that bicuspid. So this was 2.5 years after treatment. Nice thick pink tissue up here, and much less sensitivity in that area for the patient. Now she can go have an ice cream cone and You don't have to pull her off the ceiling when she's done. This is a case, like I said, does this work in the mandible? This was my favorite cases. This is Bill. He's a super nice guy. I actually just saw him a couple of weeks ago. And I know when I was doing, grafting tissue from the palate, I would see a tooth like this, just really steep, deep recession. And I'd just be like, ugh, because that's not an easy thing to treat. And he's got it on about every tooth all the way across. So you can treat all of these at once. If I'm doing this with palatografts, I'm looking at least 3, I think. This was billed 24 hours after surgery. Wow. All at once, you can treat the full arch. And you can see the little pinholes here are just completely closed up 24 hours after surgery. They're gone. It's a closed system now. And this is billed 6 months after treatment. So incredible. Significant difference. I mean, look at all this beautiful thick tissue here, right around that canine too. It looks great. I'm really happy with what I see, and Bill's really happy too, because he didn't want to have three surgeries. He just wanted to do it once, and I don't blame him. So
yeah, beautiful, incredible.
So some really thin. Does this work with really thin biotype? Yes, this is my patient Linda. She's got such thin biotype you can see the root through the thin gum that she has. So this was Linda immediately post-operatively. This is Linda after 6 weeks. And this is Linda after 6 months. It works great with thin biotype, and her biotype looks a little better now. I can't see her roots anymore, which is really nice. Right. I have a feeling this is going to be some nice resilient tissue for her, and it looks beautiful as well. And this was not an easy case. She's not perfectly aligned orthodontically. She had a little overlap in those teeth. This tooth is really buccally located, and we still got a really, really nice result. So I was very, very happy with the results in her case.
Yes, these are really, really tough case.
Yeah, not an easy one. Linda was not an easy one. This wouldn't be my first case, but she was a great case, and I'm really, really fortunate to have worked with her. And like I said, I just saw her not too long ago too for her hygiene visit, and she looks great. So she's super happy with her results.
I have a quick question for this particular case. In case if the patient had the frenum in the middle.
I've got a frenectomy case coming right up.
Oh, okay, thank you.
Here, let me skip to it. I'll skip to it right now for you. So sometimes, here's a frenectomy case. So sometimes I do a frenectomy and sometimes I don't. It kind of depends on the case. In this particular case, when I pulled on that frenum, this whole papilla would move, like the whole papilla would kind of pop out. And I said, ooh, I'm not going to want to try to get an instrument up there and sever those frenum fibers. So I said, let's do a frenectomy first. So for this case, I did a frenectomy with a laser. That's what he looked like a couple of months after the frenectomy. And as you can see, he had some steep recession down here. I mean, this is clefted to about right there. It's clefted to the depth of the vestibule. There is no attachment around this tooth. There, it's not the healthiest situation that this guy was in. So we did the pinhole technique. You can see that's his little pinhole immediately post-operatively. Very, very tiny little pinhole there. That's the case after 6 weeks of healing.
Wow.
And then this is the case after 4 months. So we're really starting to grow some nice, beautiful attachment down here. And I'm really happy with what I see in this case after 4 months.
So for frenectomy,
and a lot more healthy than it did preoperatively.
For frenectomy, you do it. You wait. How long you wait before you do the?
I personally wait 12 weeks. That's a pretty conservative number. But I was raised by a periodontist, and maybe I'm just a little bit of a conservative dentist. So I wait 12 weeks. I used to wait a little bit less, and I noticed that the tissue there just was looking a little thin, and I wasn't happy with it. So since I've started waiting 12 weeks, I haven't had any issues at all, and I'm happy with that. That seems to be a comfortable time frame for me. So I usually do the frenectomy. If the patient needs a frenectomy, I offer it to them the day they come in. I say, hey, we got your treatment plan for a frenectomy. Let me get the laser out. Doesn't take too long to do. I'll see you in a couple of weeks to make sure it's healing properly, and we'll start our 12-week timer, and then we'll do your pinhole in a couple months. And we usually do it that way, just get the frenectomy out of the way. So that seems to work out pretty nice.
Yeah.
It's nice to be able to offer patients same-day treatment. With the laser, the frenectomy, it's pretty quick. So it's a procedure that you can do and squeeze in the middle of your day, or squeeze in while another patient's getting anesthetized, and just kind of get it out of the way and start the timer for healing.
What laser system do you use?
I have more than one laser. I have a diode laser. I don't use it very often anymore. I also have a periolace.
I see.
that I use for periodontal therapy, and it also has a diode mode on it, so I use it in its diode mode. So every once in a while I'll break out that diode laser if the periolace is getting used by another patient, but normally I'm using my periolace and either in its mode to do its thing or in the diode mode to do tissue work like that, or gingivectomy or whatever we need to do.
Thank you.
You're welcome. This is a really nice case illustrating how you can combine the pinhole surgical technique with restorative dentistry. So my patient, she has a big filling up here, you can see on the bicuspid, and she's got this crown that she hates. She just says, I got one really big tooth, and actually you can see the cement. The crown is actually failing on the distal buccal, so the crown needs to be removed anyway. Not only is it not particularly beautiful, but it's not particularly healthy. So I told the patient, well, why don't we just do the crown and the pinhole technique all at the same time? That way you only have to, get done once. So I took the crown off and I took the filling out as well on the upper left side. And we did the pinhole technique. You can see I took the filling out. There's nothing there. Took the crown off. Moved the tissue down over the margins. Made a temp and cut it down real short so that I get really good healing. So she's in a temporary crown here. So this is immediately post-operatively. Already looks better. Much more aesthetic, much more symmetrical to the other side.
Yes.
This is 1 week post-operatively. It looks pretty nice after 1 week. And you can see on this left-hand side where that filling was, it's completely gone. This was 3 weeks after healing. And at this point, I'm getting some really nice tissue here. And I'm going, I wonder if I could trim that temp back a little bit. So I did. I trimmed her temp back a little bit at 3 weeks just to say, hey, how much gum can I get here? And at 6 weeks, that's what we got. So it looks really, really nice.
Wow,
really beautiful.
This is considered advanced aesthetics dentistry. I love it. Beautiful.
Yeah, and it's nice. It's nice for the dentist too. In a couple of hours' time, I get a full arch pinhole fee. I get a crown fee. So that's a nice day of work for the dentist, as well as a beautiful service to provide for the patient. And then, this is our before and after. So that's much more cosmetic. I think her canine teeth are looking a lot more symmetrical there. Wow. And then the patient was so happy with her results. She said, well, can you treat my bottom teeth too? So we ended up doing her lowers. Wow. So that's her post-operatively after her lower teeth. So when the patients see what a good job you do, they just want you to do more stuff. Excuse me.
Beautiful.
But it's a really nice procedure as a general dentist that I can do the prosthetics and the perio kind of all at the same time. It's much more efficient use of my time in the office. It's a much more efficient use of the patient's time. After healing, she just has to come back, take a final impression, refine the margin a little bit, take a final impression, and she's done. So it's a really nice, efficient use of the patient's time, as well as a really nice, efficient use of the doctor's time, and gives a really beautiful cosmetic result. Like I said, you can't tell that there was any grafting done in this area. It looks perfectly normal, like nothing ever happened. Right. There's no scarring. It's really nice. And no sutures. Like I said, hey, suture, I don't know if you ever had sutures in your mouth, but they're really annoying. They're kind of annoying. Nobody likes them. Nobody enjoys them. Absolutely. So it's really nice to be able to provide a suture-free option for patients so that they can go about their daily activities and not have to worry about having stitches and having them taken out or having them falling out or having them annoying. So it's a really great procedure. I'm really blessed. Like I said, I thank Dr. Chao every time I see him for teaching me the skills to be able to provide this service to my patients.
Absolutely beautiful.
Yeah, so I kind of skipped, so we can go. I have a couple more if you want to see more stuff. I could sit and talk about this stuff all day.
I think we might be out of time.
Oh, that's really great. Well, I'll put my information back up and I'll throw it back to you here so that you can put yours back up there.
I really appreciate your time, Deanna. You have so much to offer for those that haven't been able to have a chance to take this class. And I appreciate your time today, joining me with, on a Veteran Day. And, happy veteran. And again, if you have your contact, you can please, leave it up there. So some of the doctor who haven't have a chance to take any this course before they, they might have any concern, they can contact you if you don't mind.
No, that's fine. I'll go ahead and share that information one more time so that you can see my contact information here. Share screen. There we go. So there's me. Like I said, if anybody wants to email me, is probably the easiest way to get a hold of me. That's my office phone number. If you try to call my office, my receptionist probably won't let you talk to me because she likes it when I'm staying busy doing teeth and not talking on the phone. But if you email me, I'll definitely respond. If you're on Facebook, you can search for my name on Facebook. There aren't too many Deanna Schnitzers out there, and I use that same picture on my Facebook, so feel free to send me a Facebook message. I love talking about this stuff. Obviously, I'm happy to answer any questions that anybody has about my experience with this procedure.
You know that with the opening of this technique, there is so many things you can offer in conjunction to just treating the gum and the aesthetics and the the combination of general dentistry and gum rejuvenation. It's all so important to have this skill on hands for those who do complex case. Do you agree with me on that?
I do. You know, there's so much you can do for patients, and like I said, you can really condense their time in your office by doing these procedures in conjunction with one another. If you can get them in a really beautiful set of temps and do their gingival work, make a nice framework for your final veneers or whatever all at the same time, patients are going to love that. They're going to be like, you mean I just have to show up once? They leave your office with a brand new smile, and then after 6 months you refine your margins and take an impression, and that's all you have to do. You've got that beautiful pink framework for your cosmetic dentistry. So it's really, really wonderful to be able to offer all of that to the patients all at once.
Deanna, thank you again for your time. You have a wonderful day.
You too. It was so nice to speak with you. Thank you.
Take care. Bye-bye.